Hello everybody. This feels like a perfect segue from the previous conversation about how do we rise this up in terms of the priorities for both health leaders in health services but also in the system. And so with that in mind, I might hand over to Kim and Chris for a presentation to open the discussion.
Wonderful. Thank you so much for having us. We are delighted to come today to talk to you a little bit about the value of genomics. And what you will have heard already today across all the presentations is that it's been a really strong point of discussion. How do we measure it? What's the trade-off between value and cost? And as health economists, when we think about new innovations, and we think about them a lot, we'll often hear the patient benefits are really being driven, and that is rightly so. But as health economists, we've also got to consider the costs of delivering that improvement in patient outcomes. And what we see, most certainly in genomics, is as per any other health innovation, that there's an initial cost. There's costs of testing, and we know that's declined significantly over the last couple of decades. But there's costs of staffing, of expertise, of processes, of data, of privacy. And all of those things can put pressure, and do put pressure, on a health services budget and on a wider health systems budget. And so when we've done work with Melbourne Genomics and the wonderful team of researchers and clinicians that have been working to see genomics adopted across the state, what we've seen is that actually when you compare the cost, you start to see a whole range of different arms of benefit. And that's not just here and now. It is here and now, but it's also wider and longer term as well. And when you start to incorporate those types of extra arms of benefits and start to value and measure those, the value equation really starts to stack up. On the graph that I'm highlighting above, it's a very standard health economics graph. It's called a cost effectiveness plane. And we've got two dimensions there. We've got costs and we've got benefits. And what we're looking at there is that trade-off. How much benefit can we get for that extra cost that we're spending? And is that reasonable to the decision makers that we've just heard have got really significant cost pressures and budget pressures that they're facing? And so in working with Paul James, and you've heard from of his amazing work, and of Kush and of Courtney in cancer and kidney disease, what we've seen is a range of different benefits. And so if I talk you through some specifics with transplant care, when we start at the immediate benefits, so that the benefits directly to the patient right at the time when they're talking about their transplant, one of the initial things that Paul spoke about this morning was pharmacogenomics, and that ability to better match drugs and doses to the individual patient. So quite amazingly, even today, there's still a lot of trial and error. When a drug or a device is funded on the PBAC, that's done based on averages. And of course, no person is an average person. And so when clinicians are prescribing drugs, they're hoping that what normally works is going to work for the individual in front of them, but it might not. And pharmacogenomics gives us that opportunity to completely bypass that trial and error. In work I've done with the Victorian Government and health services across the state, we've been looking at productivity of health services across the last decade or so. And what we've seen is it's a real challenge to drive productivity growth. It's a real challenge to get better patient outcomes and more patient throughput with the same amount of staff and funding that we've got. What pharmacogenomics and genomics in general can do is actually help with that. It can be a real driver of productivity because it lets clinicians, lets a health service actually be much more prescriptive about what's going to work for that particular patient. But then we start to think about the wider and longer term benefits that genomics can offer as well. When we think about the transplant care that Paul and his team have been working on, early detection of conditions that genomics offers can actually provide an opportunity to intervene early around things that might happen after a transplant and completely change a long-term patient trajectory by doing so. And then there's wider benefits when we talk about family members as well. So there's also the opportunity that a test can then identify something that, hey, we need further testing of a family member, and that can lead to, again, early detection of conditions and diseases that can be intervened in, and again, change long-term patient trajectories. So really strong value arguments that we think are really starting to be prosecuted. There's no doubt there's still a cost, but when we start to really delve into it, we do see that the value argument does start to play out, and the cost effectiveness of genomics becomes really stark. Now, that doesn't mean that there aren't real challenges, and you've heard from the leaders of health services just prior to our conversation about some of those. Clearly, budgetary pressures are always stark, but particularly so at the moment. And there's always issues around staffing capacity. And I think it's probably worth taking a moment to reflect. When I was looking at the graphs last night, and Paul mentioned it again this morning, that 2 decades ago it would take a year to do a test, and the costs were hundreds and millions of dollars. Today, and I guess to the slide on the screen, the key thing there was that there was really low access. And one of the things that Melbourne Genomics has done really well is focus on different models of care to be able to expand that access. And so what we've seen through some of the work that you've heard about earlier today is that we've broadened, and Melbourne Genomics, the work that they've been doing has been able to broaden that access. And in doing so, and by doing so, they've been able to actually lower the average cost of treating a patient as well with genomic medicine. And they've done that by really being able to adopt step models of care, so that not every patient interaction needs to be with the most experienced and trained clinical geneticist, but there's ways, different models of care, different super user models, different centralised models, telehealth models that can actually provide step models of care where a local clinician, a clinician that consumer would prefer to talk to, is able to provide a whole lot of the services that are still required. So a whole lot of positives on that reflection. One perhaps opportunity that I'll provide just before I throw back to Lucy and Kim is that some work that we've just published recently highlighted how much we as a country spend on federally funded genetic and genomic tests. And I might even just throw it over to the audience to see if you've got an idea. I'll give you an indication. We spend a couple $100 billion on all of our healthcare that we fund through our MBS and PBS. How much do you reckon we spend on federally funded genomic and genetic tests? Anyone have a guess? 20 million. It's a little bit more than that. It was 76 million in 2023, but less than 0.1% of our overall federal spending. Now, I'll put the caveat, good academic always should, that not all of our genomic tests are funded through MBS and PBS, but it just highlights the opportunity that there's still a whole range of work that needs to be done to continue to grow the utilisation and the access of genomic medicine across the state. Thanks. Lucy.
Thanks, Chris. If I open, you've touched on the kind of critical tension point between the value to the health system and the population over time, and then the realities of what the health services are managing each day. Kim, if you reflect on a couple of the things that Chris has just called out about productivity and step models of care, are there other ways that you think, is there additional flavour to that, or other ways that you think genomics can help health services grapple with those daily realities?
Yeah, I think that initially hospitals, obviously, and health services are working to a set of incentives that are real. So we need to be realistic about that they're funded, hospitals predominantly, on their activity-based funding models, supplemented with some block funding. So that's the reality of that funding situation. So we think that there's some strong value propositions around genomic care, around the opportunity to increase efficiency within those systems, and that will provide some really real benefits in terms of uplift to those systems. Chris and I have been reflecting on that if we can get the right test earlier, it really can produce a lot of savings in terms of avoiding tests that are less necessary and lower value care. And at the same time as doing that, there's, we think, some quite important value to the workforce as well, because it's super frustrating for really smart people to be working in a system that they understand to be low value and wasteful and not delivering best outcomes for patients. So we think there'll be productivity impacts as well to the workforce when they're participating in a system that's more efficient and getting the right care to people more quickly and more efficiently. I think it will be reflected in the funding models, but I guess some of our incentives in how the funding will not fully reflect that too, because of that tie to the activity base. But I think the efficiency will come through, and then the outcomes to the patients. We are going to be then preventing some of those worse outcomes for patients that penalise hospitals, such as the hospital-acquired infections, the long stays, where we get financial penalties in the funding models through bad outcomes to patients, through directing better quality care earlier in the sequence of care. I don't know if Chris had anything to add around the value proposition.
As a former health CFO, these are all the things that I would usually be looking to hear from as we start. And then adding to Adam Horsborough's thing about how do we align this with system reform, about care closer to home and better care coordination. So that's all in there. Which leads into that next question about how the evidence base that we're starting to build to advocate for the health system. How do you see how health services can use this information to advocate at a system level, both state and federally?
Yeah. So we want to do the very best we can within a health service, and then at the same time be trying to leave the whole system better. So we know our system's not perfect, and I think genomics has it's not unique in the challenges that it's highlighted about the overall system, but it has highlighted issues with a system and with our health system, such as the ability to wrap implementation efforts and appropriate workforce around this effort to deliver genomics care, the ability to communicate across silos and sectors in our health system that genomics kind of raises for us. So whilst doing the best that we can within services, we also want to be challenging the system to do a better job too. And I think that genomics has brought us some data, some evidence, and some imperative to advocate for systems that do a better job as well. And we've got good test examples and good cases from genomics that can highlight those issues and prompt us to do better at a system. Also, I guess from an economics perspective, the funding models often let us down in terms of how we allocate the funding in a very siloed way, and genomics is challenging us to do better at allocating funding. Particularly here, we need programs rather than tests, right? We've seen from some of the prior speakers that we need genomics to be rolled out as a program and a system of care, not just as an individual test that then has no funding to follow the response. And I think it's prompting us to think about how do we then wrap funding models around that care that will support patients to get the follow-up as well as the test.
Yeah, no, what I'd add is in terms of the technicalities of providing the evidence, in health economics there's a word that we use a lot, and it's called perspective. And when we do an economic evaluation, it really matters which perspective that we take. And if we take the perspective of the hospital itself, we might get a very, very different answer to if we took a wider perspective of the government paying and the health funder paying, or of society when we're considering cost to consumers, inequitable access, travel time, waiting time, etc., not knowing. And so actually taking the time, and some of our colleagues in the health economics of genomics have been doing a really lot of good work in this space to consider wider perspectives when we provide that evidence base, I think is really crucial, so that everyone can actually look at the evidence base from the perspective that matters to them.
Yeah, absolutely. And that patient perspective about low value care and being able to reduce that so that they're really getting care at the time that they need. And so some of the cases that have been spoken about today, and you've used the transplant care one, which is a really great example of how things have changed over time. What's the next big opportunity for innovation?
Well, we were talking about this, and unsurprisingly, as health economists, we think it's so crucial to get the kind of the testing system really bedded down in place, so that you're not duplicating effort and duplicating cost. And one of the things that we saw when we were doing our research to try and uncover, well, how much are we as a country and we as a state spending on testing and genomics? You can't go to one source. Actually. The federal government pays some, and the state government pays some, and some comes through hospitals finding money out of a kitty, and so making sure they're actually on top of that, I think, is really critical when we think about access. And we actually want to be able to highlight areas and cohorts of people that are missing out, because we can't do that, we can't do anything about it. And so making sure that we've got the systems in place to actually be clear about who's getting access to genomic and genetic tests. And pulling that information, that data in a systematic way, I think is a low-hanging fruit piece of innovation that would actually really help as a broader system to hit the goals that we want to hit.
Is that a particular issue in Victoria? Like, is it easier in other jurisdictions than it is in Victoria, or is it a national challenge?
Yeah, national from what I'm seeing, and even in looking at places like the Northern Territory and WA have very sparse rural areas, and so often have very different funding models of different services, which is great. And sometimes those funding models are really apt, but they make it really difficult then to see what's going on. We don't do a good job of then being able to collate that. If there's been some block funding for certain services or certain regions, and then we've got activity-based funding or data on specific tests, we're really struggling then to see the bigger picture, and to say, well, are certain cohorts, certain critical cohorts missing out?
Kim, did you want to add to that?
Yeah, I've got a couple of ideas. I mean, I think that some of these populations who are missing out could be our very biggest value proposition, right? So I guess just to add to Chris's point, in terms of a few radical ideas here, I think one of my big radical ideas, which will link to value and efficiency, is just making sure that the data is following the patient. And I guess I'm not an expert in this, but I really wonder whether it should be more data control and ownership by the patients themselves, whether it should be in their My Medicare or, appropriately password protected. But I would hate to see that we are retesting any patient that doesn't clinically need a retest just because we are unable to share data across systems. That would be so wasteful. And also, I think the other area that we really think a lot about is it comes right back to the definition of value. So when we think about value, the ways that genomics has really challenged us is it's pushed us to think differently about value, because where value lands is not just to individual patients, it's also to families, and it's not just to health outcomes, it's to outcomes beyond health. So things like hope, the value of future testing results, the spillover effects that are beyond what we traditionally think about, like psychosocial impacts. So when we think about value using that broader framework, that's all patient-orientated thinking. It's all what matters to the patients. And thinking about next steps, I'm wondering if we're bringing enough patient lens to how we're designing and valuing our programs. So if we think about how we design genomic care, genomic programs, are the patient preferences being systematically generated to inform what it is that patient's offered, in terms of, so I think we have methods that are capable of generating patient preferences around risk, around uncertainty, around their preferences around delivery of care close to home, far to home, costs, willingness to pay, a whole range of their preferences that may dictate how they would like to interact with genomic services that would dictate the value of that care to them individually. And I think that if we assume each patient's the same and that the value of care would be the same to every patient, then we're missing an opportunity to optimise value. So the methods are there for how we could do this, but I think it's a really big opportunity to bring bigger patient voice, bigger patient preference into how we optimise care and take into account their preferences in the delivery of our services and care.
It's really exciting.
Yep.
If I think, I lost my train of thought. I got so excited by the idea of kind of more patient voice in helping us define the models. I know what it was. It was picking up on Eugene's point from the previous session, he kind of gave us the provocation around maybe the value is in that equity piece if we're using this to the equity piece. And I just wondered because if you had any reflections on that, and maybe that's the way to help us advocate at that system level as well, which I think probably follows on from some of your comments.
Yeah, because if we think about value, we have to quantify benefit. And for underserved populations and vulnerable populations, often there's a bigger amount to be gained through the optimization of care. So then when we do the economics, cost versus benefit, that benefit side of the equation is often huge. If there's a greater vulnerability, a greater risk, and a greater opportunity to benefit, then that's how the cost effectiveness equation will stack up really strongly for those populations. On the other hand, I can challenge us more in terms of the models of how we get the care to those populations, and it can be more expensive to get the care there, and we might have to work smarter in how we get care to everyone. So I think Chris has done some thinking about workforce in terms of, is it the same workforce model that gets care most effectively to all populations, or do we have to be smarter about how we optimise our workforce? I don't know if you have thoughts on that.
Well, and more broadly, one of the critical things, and it was mentioned again earlier today, is just on integration and coordination. What we saw in some of the work that we did that increased access for genomic testing, but then that potentially led to the requirement of a further treatment that wasn't available in a particular area. So making sure that there's coordination at that broader level, I think, is really critical too, because sometimes it can actually then help, but then the next step isn't available and can further exacerbate that inequity of access.
Which is where the idea that the data follows the patient starts to become incredibly valuable as well. That's great. We're sort of coming closer to lunch, and I'm aware that everybody here has been listening for a long time today. Are there any other burning thoughts or reflections from the discussion earlier that you've heard and how that plays into the value proposition of genomics?
I think the main things I'd want to stress is just that the importance of the whole program, not just the tests. Like, we've heard that a lot today, but from the economics that follows, like, it's about the whole journey for the patient, not from the test onwards. The other thing I think that I'd like to stress is that, like, whilst value is about cost and is about an investment, most of where we recoup value will be about in the events that follow that are the things that matter most to patients. So keeping that framing on things that matter most to patients. Some of them incur costs, like readmitting to hospital and having bad adverse events and having a lot of unnecessary testing, and those things incur costs. But there's a lot of the value proposition that will pop up along the journey, which is really orientated around things that matter a lot to patients. So productivity impacts, caring impacts, impacts on their quality of life, and the ability to live a healthy and well life as a result of what occurs after the testing. So I guess it's just keeping our eye on that patient orientation, because ultimately the value comes from the outcomes that matter the most to the patients too. Yeah, agreed. Chris?
Yeah. I guess my major reflection has just been that we're already bearing the cost of imprecise medicine. We bear that every day. in hospitals and in a healthcare system. And so we just need to be cognizant of that when we think of yes, the cost of genomic medicine, but we're also already bearing all of this cost, and that can be saved or mitigated to a significant degree.
It's been really helpful to hear the examples of what we've already achieved, but also the challenge that the information that you're gathering around how do we do better at that system level. So thank you for your expertise and contributions. I think that's us wrapping up towards lunch now.